I'm going to be discussing a number of aspects of brain stimulation for movement disorders. I don't have any relevant disclosures. UAB's recently became a Bachman and Strauss Dystonia Center for Parkinson's, or Center for Dystonia and Parkinson's Disease, and so this has been a new focus in our group, and the PI for that is Dr. Standard, who's here. I'm going to give an overview about brain stimulation, talk about the FDA-approved indications. I'm going to describe the procedure, and I'm going to have one slide devoted to each of the movement disorders indication with accompanying videos to show some examples of patient outcomes. And then briefly at the end, I'm going to talk about some of our research interests at UAB that we're trying to use to optimize targeting and stimulator adjustment, and also to optimize battery longevity in these patients, which is an important parameter to follow that has both patient morbidity and health economics implications, and also talk about our series looking at potential adverse events from this surgical procedure. So brain stimulation is not an experimental therapy. It's been approved by the Food and Drug Administration for some time. Patients with Parkinson's disease benefit from stimulation of the subthalamic nucleus, which, as the name implies, is just below the thalamus within the basal ganglia, and then the globus pallidus interna. Generalized dystonia is treated with bilateral globus pallidus interna DBS. Essential tremor is treated with unilateral thalamic stimulation, and recently there's been an FDA humanitarian device exemption for refractory OCD, stimulating the anterior limb of the internal capsule. And there are a lot of new indications that are being explored for DBS. And it's a really growing area, both in neurology and psychiatry. I think it's very important for us to understand how DBS works and to have a better understanding of what is really therapeutically relevant about the brain stimulator to optimize the therapy moving forward. I would argue that the application and use of this therapy, both investigationally and in real clinical practice, is actually sort of outgaining our fundamental knowledge about how it works, and I think that needs to be a future emphasis. So the brain stimulator for Parkinson's disease, this depicts subthalamic stimulators. The leads are not this large. There's a magnetic susceptibility artifact around each of the contacts. There are 4 electrode contacts in each DBS electrode. It's a linear array that's in the basal ganglia. And these devices are connected to a pulse generator or battery, and there's a wire that's underneath the skin. So it's all internalized, and it's programmed with a radio frequency signal from outside the device or outside the patient's skin. And this is a really important collaboration between neurology and neurosurgery. And we have to work together very closely to provide this therapy. There's a lot of evaluation and management that leads up to the decision to have surgery. There's the intervention itself and the battery changes and other things that go on over time in terms of the surgical aspect. And there's a lot of fairly intense management that occurs along the way as well. All of our patients have psychological testing, a brain MRI, and are discussed in a committee where neurologists, Dr. Guthrie and the rest of the neurosurgical team and the neuropsychologists talk about each patient. We like to just have a sense of the patients who are being referred. We review detailed neuropsychological testing, we look at their MRI, and then we decide whether we recommend DBS or under what circumstances we might recommend it. And we are really making a lot of efforts to, especially with some of the new electronic medical record tools, to communicate with our referring physicians, and I think that we're doing a better job. Certainly we've always tried to do this, but some of the new tools, despite some of the drawbacks, I think that the electronic medical record system is very powerful in terms of being able to distribute information rapidly to referring physicians and other caregivers. We, of course, want to recommend DBS for patients who are likely to improve a lot, and we want to minimize risk as much as possible. And at least with the current devices that are available, you cannot have an MRI with the body coil. So you can't have an MRI of your hand, your knee, your ankle, the cervical spine. We can safely, we always get an MRI of the brain under certain parameters that we know are safe after every surgery, just to evaluate the location of the lead within the brain. And this is just to discuss some of the targets: the subthalamic nucleus, the globus pallidus interna, and then the thalamus. And DBS acts on a complicated system that has a lot of different nodes and relay stations. And the end result, at least in the motor system, is activity, the alteration of activity in muscles, which are the primary effector organ of the distributed motor system. And you can go ahead and start this. And so this video shows a schematic, or just a brief time capsule of the surgery itself. And so this is the burr hole, and we do microelectrode recordings to refine the target. And this video was made by one of our former fellows, Gerald Callaghan, who runs the DBS Center in Baton Rouge, Louisiana now. And so we get an MRI with these fiducial marks that are around the frame, and then select the target based on the individual patient's anatomy and upon sort of canonical coordinates for these different stereotactic targets. And one of the roles of neurology in the surgery is to identify the parts of the brain that are involved in these abnormal movements. And in this case, these are subthalamic units. And so this is the dorsal part of the subthalamic nucleus. And you can hear the voice of the president of UAB, Dr. Watts, in just a moment. That's Dr. Watts there. And I trained to do these microelectrode recordings with Dr. Watts back when I was a fellow. So these are subthalamic units in a human with Parkinson's disease. So you can see this patient has a lot of tremor. He's shaking the frame, the stereotactic frame. That's a raster. So the Parkinson's rest tremor, about 4 to 6 hertz. Occasionally you run into these tremor cells. Turn the stimulator on in the OR.
Okay. Open, close your hand. Woo. Good. Tap your finger to your thumb. Fast as you can go.
Wow, that's a lot better.
Pretty remarkable. That's 4 volts.
There we go. So you can go ahead without the volume, start the next video. So both subthalamic and palatal DBS are superior to oral medications for the treatment of the motor symptoms of Parkinson's disease. And this has been shown in a number of randomized trials that randomize bilateral subthalamic stimulation to best medical therapy. This is a patient with tremulous Parkinson's disease. You can see the asymmetry, very severe rest tremor in the left hand. This patient also has asymmetric bradykinesia and rigidity. And subthalamic stimulation, as well as palatal stimulation, improve all 3 cardinal symptoms. So that it improves tremor with rest, and with action posture, it improves bradykinesia and rigidity. And it really very markedly improves levodopa-induced dyskinesias as well. In general, the response to DBS is predicted by a good response to levodopa. So if a patient responds very robustly to levodopa, it's more likely that DBS will be beneficial for their symptoms. And tremor is an exception to this. So there are some patients whose tremor never responds to levodopa or dopaminergic medications to any significant extent, and DBS is still markedly beneficial in these scenarios. You can see the patient had almost no arm swing on the left, just tremor and decreased arm swing on the right. And so this is after just a single subthalamic stimulator unilateral DBS 3 months after surgery, again in the off-medication state. And subthalamic stimulation is very potent for tremor, but you'll notice in this patient, you really didn't even notice that he had tremor in the contralateral arm. And this patient went on to have stage placement of the stimulator on the other side of the brain. Our practice is to do unilateral stimulation, and then we follow it with the contralateral side whenever it's clinically indicated. There are many patients who go for years with just one stimulator. And we think that this approach minimizes some of the potential complications of the surgery, which I'll get into later. But the response to DBS is sustained for many years, as long as anyone's ever looked. Tremor and dyskinesia and dystonia respond very, very dramatically. My sense is that over 10 or 12 years, the response in terms of bradykinesia and rigidity may wane somewhat. It's not a cure for Parkinson's. It's a very helpful symptomatic therapy. Some of the levodopa unresponsive elements of Parkinson's disease, like freezing of gait and postural instability that become so problematic in patients with advanced Parkinson's disease, DBS really does not help those symptoms as much as we would like also. And so what we find over these patients over time is they have very marked benefit, but they still have a lot of the issues that patients with advanced Parkinson's have, and gait problems become more problematic 5 and 10 and 12 years after the placement of the stimulator. So you can start this video as well, the first one. So thalamic DBS is very, very effective for essential tremor as well. This is a video in the operating room. That's Dr. Guthrie. And so you can see the action and tension tremor in a patient with essential tremor. And they've given this patient a bottle that was just in the OR because he, as so many patients with essential tremor do, complained of trouble with drinking liquids and using the hand. And so here, Bart tells him to activate the stimulator, which has already been implanted in the brain. And they're just talking about that. He'll get out of the way. So with the stimulator on, that's it. That's what this therapy does. It's very instantaneous. And so now the patient can extend the hand off, and Bart says, turn it off. And just like that, it comes right back, the tremor. I never get tired of seeing it. It's just a magical thing. There are these rhythms that are in the brain, and you can put an electrical stimulator in a node in the brain, and so reversibly like that, remove these involuntary movements. You can click on the bottom one now. So really what we look at with patients with essential tremor is problems with writing, pouring, other activities of daily living. And those things, it's that contralateral hand that gets better more predictably than anything else. It's harder to help tremor in the vocal apparatus. It's probably hardest to help tremor in the vocal apparatus. Tremor in the head gets some better, but tremor in the contralateral hand and often the contralateral leg, we expect it to be suppressed by 80% or more. And especially with thalamic stimulation, dysarthria is common with bilateral placement. We really would like to implant the contralateral arm, the contralateral dominant to the dominant arm, and hope that will leave a patient with enough improvement in their quality of life that will be sufficient. And this video was just from a newscast that's in the early 90s, just to emphasize how long. I mean, this is a very routine procedure. We do these all the time. I'll end with palatal DBS for dystonia. Yeah, go ahead, please. And bilateral palatal DBS is very effective for dystonia. Dystonia is an unusual syndrome where there are involuntary twisting movements. And mostly brain stimulation has been studied in primary generalized dystonia and severe cases of cervical or segmental dystonia. This lady was implanted around 2005. She still has marked benefit from DBS. And if you could turn up the volume now. She's a... You can see the drawing movement in her face here.
Yes, trying. Hold.
So this is Hemorrhage syndrome, the craniofacial dystonia. And this woman would have very painful, debilitating dystonic spasms in her facial muscles and in her neck. But as you'll see in a moment, she also has dystonia in the arms and legs.
Okay. The chin, yeah. Both arms. Okay.
So you can see the abnormal posture in the hands, a kind of an irregular, more slow tremor, as is typical of patients
And
with
we need to
dystonia.
do this. I know,
And
as much
again, the
as you
drawing of the
can.
face,
Waiting.
platysma.
Take 5 to 1. Okay, that's good enough. Try to do it with this one. Or we can we wait?
And you can hear Nadi
Knee
Stover,
to
one of my
heel,
colleagues.
Up and down with the other heel. Just do as much as you can. Up and down. Now up.
So probably the best study still that's been done evaluating DBS for dystonia is this study by Cooch, where they randomized people to bilateral stimulation with either sham stimulation or real stimulation, and they found significant improvement in the real stimulation arm versus the sham arm. In the sham arm, they activated the stimulator 3 months after implantation.
Hospital ship heads for home
Now,
after treating.
This woman has an absolutely remarkable improvement in her vocal apparatus. And a lot of patients with generalized dystonia have trouble speaking, and this is actually not really typical. I think that it's a really beneficial, but palatal DBS, kind of like the thalamic DBS, it really tends to help the extremities more than it helps the voice. And I don't know, I'm interested in your opinion, Dave, her voice abnormalities. I've wondered if it's a dystonia of her pharynx. I'm not sure if it's spasmodic dysphonia. Yeah, and so that's been a question that's come up in the past about why some patients' voice, most people, their voice doesn't improve so markedly, but she did. And one of the very interesting things about DBS for dystonia is that, first of all, the more mobile and rhythmic symptoms respond more rapidly. And the more fixed and severe the postures are, the less they respond and the longer it takes. And in contrast to essential tremor or Parkinson's disease, where the effects are so instantaneous, there can be delayed effects in patients with dystonia where their benefit happens weeks, or in this case, you'll see even months later. So she still toe walks here. And this is 3 months after bilateral palatal DBS. And then this is the same patient more than a year later. And you can see that her mobility is dramatically improved.
Come on back. Come on, turn around.
And she still has just a touch of toe walking. You can see how she walks on the foot there and limps slightly. Go ahead and click on the next video. So this is a patient with very severe cervical dystonia. Most patients have the onset of cervical dystonia in middle age. His onset was in his teenage years. He didn't have a family history, so it seems to be a sporadic case. But you can see that the dystonia affects, in addition to his head and neck, his shoulders and other adjacent body segments as well. And he was injected by Dr. Watts over a period of years, and patients with really bad cervical dystonia can benefit from DBS when the response to chemical denervation with Botox or Myblock and so forth is no longer satisfactory. And so this is 6 months post-op, and that he was born with that abnormality. So you can see in his case, even though he had a really abnormal posture, even the abnormal posture in his cervicothoracic spine improved. And that's actually Rohit Dal, who's hiding from the video. But Rohit is now the director of the medical director of the DBS program at the Barrow Neurological Institute in Phoenix. And he was one of our fellows. So one of the things that we've been doing lately is looking at a very important outcome, which is the longevity of the battery. One of the things that we found looking at a retrospective slice of our patients, more than 500 patients, and some of the residents and at the time medical students were involved in this chart review. These are Kaplan-Meier survival curves, so at this time at 50%, half of the batteries have expired. And so patients with essential tremor and Parkinson's, the battery lasts about 3 to 4 years. Whereas in patients with dystonia, the battery expires at about 2 years' time. And part of the reason for this, we think, is that delayed response to the stimulation. When you never know exactly which contact to use. You don't know how high to turn it up. We probably err on the side of stimulating too aggressively because basically we turn the device on and just jack it up. Because there's no symptomatic response to drive the clinical decision about the amount of stimulation, whereas in a patient with essential tremor, at 2.5 volts, the tremor's gone, you know to stop. So although this is not surprising, it's a huge health issue for these patients because a patient who is 27, for instance, and has stimulators placed on both sides of the brain will have their battery changed every year for the rest of their life at the cost that I mentioned. It's a massive health cost and a lot of surgical morbidity potentially. And as I just alluded to, the programming is actually very complicated. It's a large parameter set, and it's very important to be quantitative and detailed in the postoperative management of these patients. And it's critical to the success of any DBS program. You want someone to do this who does it all the time, who's done a lot of cases, and people where there are dedicated personnel to do the programming and there's availability. Not to bog you down with details of this, but this is just a beautiful study showing individual patients with different kinds of tremor. And what you can see in this reach to grasp task is that which stimulation contact is used makes a marked difference as to the amount of tremor. So it's very important to be very detailed and to spend a lot of time with patients in terms of the postoperative adjustment. And we're interested, I'm not going to talk long about this, but we are interested in developing electrophysiological biomarkers to predict whether the stimulator will work in the location that it's placed in the brain. And this is an evoked potential, actually. And we use techniques to remove the stimulus artifact. And what you can see is that the brain response to a given stimulation pulse increases in amplitude with the stimulation voltage. And this is associated with the suppression of tremor in patients with essential tremor. So we're now evaluating these EEG waveforms actually rather than in the ambulatory setting in the intraoperative environment to see if it can be used as a proxy to predict both outcome but also potential adverse events from stimulation. And we're interested in actually localizing these potentials. We've been looking at them and actually published our results in 2 papers in movement disorders last year, one showing this physiology in patients with essential tremor, and in another looking at patients with subthalamic stimulation for Parkinson's disease. In general, these responses seem to localize to the ipsilateral cerebral cortex with respect to the location of the stimulus. And we're trying to work out the details of this. Understanding the cortical physiology of DBS could actually lend insights that could, in a more hypothesis-based way, provide potential strategies for less invasive forms of cortical stimulation for movement disorders, which is something else we're interested in. And we've actually been able to distinguish between effective and ineffective stimulation sites within the same patient. And so this is a really big emphasis of ours. So these are all different patients. This is the evoked potential in the same patient at different stimulation voltages. And the red sites are effective stimulation sites. The purple are sites that were poorly tolerated. And you could see this remarkable change in this non-invasive cortical physiology. And we think that this could be applied to really optimize in real time how a patient's stimulator is targeted. Another thing with respect to the programming is, and the battery life is different stimulation modes. And we've recently found that bipolar stimulation, where the anode and cathode are both inside the brain, confers longer battery life than monopolar stimulation, where the positive end is the case that's out in the chest wall rather than within the brain. And this is another interesting avenue that we're starting to explore. A very dramatic difference in these patients with moderate or low stimulation intensity. The paired comparison here is of monopolar stimulation, which is the solid line, and then bipolar stimulation at the same stimulation intensity, the dotted line. So you can see that if the patients have overall low or moderate stimulation intensity, that the difference in battery longevity is very marked here, greater than 1.5 years that the battery lasts. Here, once patients reach 3 years, about 1 year. And the overall improvement is greater than 1 year using bipolar rather than monopolar stimulation. The kind of canonical stimulation is monopolar stimulation. So this is something we're interested in looking at. And Daksha Patel has done a very good job looking at adverse events. And we're interested in adverse events because it's an opportunity to improve our process. And all of the studies that I've talked about so far show that when you compare DBS to best medical therapy, not surprisingly, there are more adverse events with a surgical therapy. And so for every patient, I tell them we can recommend it, but it's really your decision whether you want to do this. And you just have to accept that there's some risk of adverse events despite our best efforts. So there's about we recently did an MRI review of 512 consecutive craniotomies for Parkinson's disease, essential tremor, and dystonia. And this experience that we're about to publish is actually 4 times larger than any other published single-center experience with DBS adverse events. And based on MRI, 3% of patients have some degree of hemorrhage or edema upon placement of the electrode. These hemorrhages are symptomatic 0.8% of the time. So I usually tell patients that there is a 1% chance of a symptomatic intracranial hemorrhage from the DBS. There also were some subdural hematomas. And patients occasionally can have a seizure when the electrode is placed. We've never seen a patient who developed epilepsy, but it's just that focal cortical irritation upon placement of the wire in the brain. And then the other common adverse events are infection, 4% at 5 years follow-up, and then repositioning the stimulator to place it in a better location, about 2 or 3% at 2 years follow-up. And all of these are within the realm of the adverse events rates that have been published in much smaller prior studies. And this is another way to look at the issue of infection. So basically, I tell patients that at 4 years or 5 years follow-up, the black line here, there's a 10% chance that your device will be replaced. 1 out of 10 patients. There are multiple reasons. The green line is infection. You can see the risk of infection increases most steeply right after the procedure and then tends to plateau. The risk of infection never goes away. So if that wire breaks through the skin, it's infected, and it will have to be replaced. The rate of reposition, around 2.7% at 2 years. Some patients, it's a complex decision, and we may reposition the stimulator years later after a lot of attempts at programming. So in conclusion, brain stimulation is more effective than medical therapy for Parkinson's, essential tremor, and dystonia. I think that careful patient selection is important to having good outcomes. And despite its effectiveness, DBS is associated with some adverse events that don't happen with medical therapy. But in fairness, medical therapy is associated with adverse events as well. And one thing to remember in patients with Parkinson's is that in the early STEM trial that the Germans just finished, paranoia and hallucinations were actually less in the DBS group than in the medical management arm because of medicine reduction. I think that DBS ideally needs to be an interdisciplinary therapy with contributions from neurology, neurosurgery, and neuropsychology. And we really want to better understand how DBS works and what we can do in terms of programming and stimulator targeting to optimize outcomes and to minimize risk. Thank you very much for your attention. I'd be delighted to take any questions that you have.
Thank you, Harrison. Are there questions? Yes.
I would be grateful to know whether or not in your evoked potential studies, whether you've seen any changes with and without stimulation of the premotor potential, where you use the contraction as your trigger and then you play it, you analyze it backward.
That's a very good question, and it's something that we have had an interest in. He's referring to the Bereitschaft potential.
There was usually a paradigm with the Bereitschaft potential, but in the patient with a movement disorder, if you simply use their spontaneous tremor, use an EMG pickup as their trigger, and then once it's recorded digitally, you can play it from that back.
Right.
And yet there's no behavioral conditioning in it, but you're right, it's the cousin or the twin brother to the Bereitschaft potential.
Yeah, so EEG back averaging can be used. It's used especially to evaluate tics and myoclonus, solitary events. I would say that understanding so we have the capability to do that. We don't do it in routine testing. And the effects of brain stimulation on those kinds of potential are actually not known. It's very hard to measure the effect on the Bereitschaft, for instance, because the stimulus artifact. One thing I didn't go into is the stimulus artifact is so pervasive in the EEG signal. We've developed some methods to minimize it, and those have allowed us to actually think about ways to look at those questions more carefully. With respect to tremor, when the brain stimulator is on in effective settings, there really isn't tremor. So that's would be one limitation to trying to look at that. Yes.
Harrison, earlier today there was a discussion in the epilepsy surgery presentations about the fact that there were a large number of patients that were untreated surgically that potentially could have had benefit. Do you feel like this is the case in our Parkinson's population, or is the quality of life issue a little bit more controversial in this group of patients?
Well, I think that
The complication risk in surgery.
I think that first of all, DBS does improve quality of life. So there are two questions. The question of whether the therapy is how much it's kind of penetrated the patient population here. I would say that it's probably either average or probably greater than average penetration in Alabama, if you compare it to other neighboring states. In Mississippi, for instance, it's very underpenetrated. So I think that there is some heterogeneity within our encatchment area. With respect to quality of life, DBS does improve quality of life in an overall sense. This has been shown with even our own data looking at unilateral stimulation with the PDQ-39, and recently a group from the Netherlands looked at bilateral STN versus GPI, and both of them show very important improvements in quality of life. And this has been shown in the original Deutschel study that used intention to treat, so a more conservative kind of metric, and found that regardless of the decision to choose medicine or surgery, quality of life was improved in a group of probably 80 pairs of patients.
So you just attribute it to the awareness of the neurologists and physicians in the catchment area?
I do, and I think that there are always opportunities for patients to have DBS, and I would say I would be just happy to see anyone that someone would refer, and even, for instance, a patient who wants to remain employed, who has very severe tremor. I think that DBS could be a very good option for them. And really the early STEM trial shows that even in moderate disease, so patients who have had symptoms for only 4 to 6 years, that DBS still in that scenario was better than the medications are. So I think that if someone's at a point in their life where they're not able to do what they want to do, it could be a very good option. And you know, if someone's not is not as ideal a candidate, I'm happy to see them either way. I'll continue to offer management suggestions.